Good morning, everyone, and thank you for giving me the opportunity to present this interesting topic at KPS-APSU 2021. Today, I'm going to give you a brief review of the contemporary role of cytoreductive nephrectomy for metastatic disease, when and why. Although the original topic that I have been requested for today's lecture was when and why, however, I changed to who, when, and why, since it is important for us clinicians to identify patients who are the surgical candidate. As you already know, that cytoreductive nephrectomy, CN, is the removal of the kidney and the primary tumor in the metastatic disease status. And originally, it was associated with the occasional regression of the metastatic deposit, which was demonstrated in two phase 3 trials in 2001, which compared CM plus interferon versus interferon, and then they reported the 6 months overall survival benefit in CM plus interferon group. And after that, CM was accepted as the first step in the management of the MRCC patients. The biological effect of CN could be the removal of the immunological sink and decreased production of the cytokines and growth factors by the primary tumor and delayed metastatic progression. And finally, the decreased nephrectomy-induced azotemia. However, all of these mechanisms are hypotheses, and none of these are clearly proven. The problem is that the MRCC treatment paradigm is evolving rapidly since the systemic therapy, the development of drug is rapidly evolving. So the role of the CN could be decreased. Before discussing whether we should really perform CN, the NCCN guidelines suggest if primary tumors are resectable, and we consider tissue sampling and we perform CN in selected patients. NCCN panels agree that CN has its role for patients who are presented with hematuria or other symptoms. However, they are uncertain that whether the systemic therapies have certain roles because the systemic therapies, as I mentioned earlier, is evolving very rapidly, so that they agree that the interferon has certain role. However, for the targeted therapy or immunotherapy, they are uncertain that comparing with the CN, whether it should help or not. So starting from the targeted therapy, retrospective database studies show that overall survival benefit with nephrectomy in patients treated with targeted therapies. However, that these studies have patients who are selected for nephrectomy have more likely to have more favorable clinical characteristics. Data from the large retrospective study by the IMDC showed better prognostic profiles who have undergone nephrectomy, except for those with 4 or more IMDC risk factors, which have been listed here. However, the paradigm is shifting from large trials, as you already know. Clinicians and researchers have thought that targeted therapy have shown substantially improved oncological outcomes and could thus dilute the beneficial effect of CN. The two randomized control trials, Carmena and Certime, have been performed, addressing the uncertain role of CN in combination with targeted therapy. Two studies substantially differ from the previous observational studies, and thus providing the guidance for patients requiring systemic therapy with targeted agents. We clinicians were uncertain that CN had really the survival benefit since considering its aggressive surgical procedure. So looking closely at the result, the Carmena study published in AJM 2018 was the phase 3 trial, which enrolled 450 patients who are intermediate or poor risk according to the MSKCC criteria. This study randomized patients who have sunitinib treatment after CN versus sunitinib alone, with a median follow-up of 51 months. And the overall survival benefit, their sunitinib alone was non-inferior, compared with the nephrectomy followed by sunitinib in MRCC patients. Then we have to consider, do we have to favor systemic therapy? However, these studies have limitations, only including patients with poor performance status, minimal primary tumor burden, and high volumes of metastatic diseases. And these patients are heavily weighted toward poor risk patients. And they also excluded low metastatic burden patients who are considered as good candidates for nephrectomy. The updated results of the Carmena were published this year at European Urology, which have been extended the follow-up period from the December 2017 to October 2018. And they reclassify the patients according to the IMDC criteria, which was originally the MSKCC criteria. In the updated result of the Carmena, although sunitinib alone is non-inferior, they have shown that certain subgroups might still benefit from upfront CN. The editorials published after the updated results of the Carmena have agreed that if patients have high volume, poor risk disease, they are unlikely to benefit from CN and should be offered systemic therapy. The editorials have limited to the current paradigm since that it is somewhat different in the immunotherapy settings, which I will discuss later in this lecture. Moreover, they have also concluded that in the patients with intermediate risk diseases, we should not perform a black and white approach. We should consider combinational approach, and this would be beneficial. Then, when should we perform CN? So far, although the first report by the Carmena have shown no superior benefit for CN, thereby discouraging us from performing CN. However, extended results of a Carmena have suggested some benefits for CN. Then we should know when we have to perform CN. The third-time trial, which compared CN plus sunitinib versus sunitinib, followed by CN, which are terminologized as deferred CN, with a median follow-up of 40 months, have shown that deferred CN had the better outcome in terms of overall survival. This study has limitation with just achieving only 99 patients with the poor recruitment. However, this study have shown that the pretreatment with sunitinib may identify patients with inherent resistance to systemic therapy before the planned CN. Therefore, the response to systemic therapy, which are the reduction in the size of the primary tumor, could be considered as the selection tool. So that several prospective studies also supported the result. And not only just using the pre-surgical systemic therapy as the tool to identify patients who are beneficial to CN, the pre-surgical systemic therapy has its beneficial role in downsizing cancer to facilitate the operability of complex primary tumors. Now, however, some reports have shown that the increased wound complications and the intraoperative adhesions after the systemic therapy. However, the systemic therapy before CN has its certain role. The role of CN has also its positive impact on symptom palliation. It also removes the potential for bleeding and pain during subsequent systemic therapy. And it also eliminates the potential source of immunosuppressive or tumor-promoting growth factors, which I consider very important part because that we are now in the era of the combination therapy, the targeted treatment plus immune checkpoint inhibitors, and the role of immune checkpoint inhibitors are becoming more increased, so that we should consider the role of CN in the ICI settings. But the avoiding surgery has also its role because it could avoid surgical complications and we could start the systemic therapy in the right time. Finally, then, we have to consider who will most benefit from CN. The editorials reported in AJM have discussed who will be the appropriate candidate for CN. There are some uncertainty about which patients who are appropriate for CN, and this is really important for surgeons since we could avoid a fruitless operation, only performing essential component of care in MRCC patients. The Carmena study, which has been previously discussed only included those who are favorable for systemic therapy, excluding those with intermediate risk patients who have favorable risk for the cytoreductive nephrectomy. The reason that I suggested is that the surgeons excluded those who will benefit from CN in this Carmena study, and thereby just might look at Carmena study that the systemic therapy is more beneficial. So the two big institutions, MSKCC and MD Anderson, which was stated in these editorials, they just performed CN in the intermediate risk patients, and they had their own criteria, just not doing surgery for the poor risk patients. So, in summary, we are the surgeons, and I think that we should not abandon nephrectomy, but carefully select patients who will undergo nephrectomy. Therefore, the patient selection is the key. And many studies have uniformly agreed that pre-treatment risk factors, resectability of the primary tumor, and status of health, and presence of other medical conditions are the things that we should consider when performing CN. The last thing I want to talk about is the new systemic agents, immunotherapy. This slide I have mentioned in earlier. The role of systemic therapy is becoming large because the development of drug is continuously evolving. However, the techniques of CN is remaining still, so that it is actually the result of the clinical trials may seem that the role of systemic therapy is becoming increased and CN should be abandoned. However, that I believe that in the immuno-oncological settings, the role of CN could be different. The three trials, which was intended to validate the survival advantage of IO-based systemic treatment in MRCC relative to sunitinib. This study was not designed to demonstrate the efficacy of CN efficacy of CN. However, this study have shown that the increased progression-free survival in prior nephrectomy patients and increased overall survival in prior nephrectomy patients. Although these studies are not non-randomized, and we should not interpret this association. It's not a causation, and the prior nephrectomy status, which was stated in this trial, was that it cannot be interpreted synonymous with cytoreductive nephrectomy. However, that we should consider the role of CN would be different in the era of the IO treatment. And there are no clear studies that demonstrated either patient selection or the timing of nephrectomy in immunotherapy. And actually, the results are better in compared to TKI in the immunotherapy, so that we should know that the paradigm is quickly shifting. So, in summary, actually non-selective CN should not be performed in MRCC patients because we have another weapon, systemic therapy, targeted agents and immunotherapy, so that non-selective CN should not be performed. And also, upfront systemic therapy prior to surgery should be considered because, as I have already mentioned, it can be considered as the selection tool for who will most benefit from the CN. And we can perform upfront CN if they have extremely favorable profile, and CN should be considered in the palliative intent as discussed in the NCCN guidelines. Finally, other approved first-line treatment, including ICI, is uncertain in terms of the plus with CN. So this is the last slide. And so who will benefit from CN? Consider pre-treatment risk features, resectability of the primary tumor, status of the health, and presence of other medical conditions. So low metastatic burden, good or intermediate risk disease patients will benefit from CN, or patients who need local control with the palliative nephrectomy will benefit from CN. So when to perform CN, those who have positive response after CN treatment will actually benefit most from the CN, or when symptom palliations are needed. And you can consider upfront CN when primary tumor is aggressive, but they have low metastatic burden, and they have good or intermediate risk factors. However, this part is actually ambiguous because we don't know whether the primary tumor is aggressive or not, just depending on the WHO ISPUP grade. We have to find other biomarkers that could differentiate whether it is aggressive cancer or not. And actually, the result is that the panels and editorials just mentioned that we should consider individualized approaches. Actually, the biology of tumor is very different from indolent to aggressive, and the RCC itself is really heterogeneous, so that future studies need to have some certain guidelines to differentiate more specifically the patient into certain groups. Thank you for listening.